This 11-year-old patient exhibited spastic quadriparesis with athetosis, which necessitated the use of a special wheelchair. After spinal cord stimulation, he could sit in a normal chair without any special support. He was unable to carry out any meaningful gait pattern, which was completely devoid of any placement movement of his feet. Post-operatively, he demonstrates meaningful placement of his feet during assisted ambulation. He has begun to ambulate with a walker. His speech has improved and drooling has been abolished. This 11-year-old patient with spastic quadriparesis also suffered from poor truncal stability. Her head and neck control was compromised by uncontrolled retrocolic spasms. Her hand control was poor, secondary to the spasticity. Post-operatively, she demonstrates generalized relaxation, a decrease in spasticity, absence of the retrocolic head and neck movement, and stability, which has resulted in improved hand function. This 10-year-old female had poor head and neck stability, along with severe adductor spasms, which made it difficult for those attending her to carry out activities of daily living for personal hygiene. Post-operatively, her adductor spasms were markedly reduced. Her posture and head and neck control improved, allowing her to sit without special supports. She had poor motor control, and it was not uncommon for her head to fall into her food when sitting at a table. She was also in a special education class. Her attention span, handwriting, and general coordination improved sufficiently to allow her to attend regular school. With a 20-year history of cerebral palsy, this patient's symptoms included drooling, poor speech, and bladder control. Due to his poor truncal stability, he had to be strapped into his wheelchair and at other times required support to maintain an upright sitting position. Bladder control, drooling, and speech were markedly improved after spinal cord stimulation. He no longer needs any support while sitting. This 24-year-old female with spastic quadriparesis exhibits a spastic type of gait with poor balance. She was unable to walk unassisted. Crutches were of no help due to the spasticity and athetosis in both her arms. Her speech was also very poor. Utilizing Canadian crutches, the patient demonstrates the reduction in athetosis and increased coordination in her upper extremities. Her speech also improved. The patient was subsequently hired as a health club instructor, a position she was turned down for prior to spinal cord stimulation. She is shown here walking unaided for the very first time in her life. Marked athetosis and spasticity in her right hand and poor speech manifested in this 20-year-old patient. Along with an improvement in her speech, her athetosis was markedly reduced. Her right hand spasticity is demonstrated by the difficulty the attendant has in having to pry her hand open. The spasticity in her hand was reduced to the point that she can now open and close her hand with ease. Suffering from spastic diplegia, marked spasticity, and impairment of hip flexor function, this 31-year-old female, with her spinal cord stimulator implanted but turned off, demonstrates the severity of her hip flexor dysfunction in both legs. The stimulator is then turned on, and after 10 minutes of stimulation, she demonstrates a marked increase in both hip flexors by raising each leg. She also demonstrates her ability to cross each leg over the other and to raise both legs at once, which she was incapable of performing prior to spinal cord stimulation. This 14-year-old female demonstrates abnormal hand posture and poor coordination in both upper extremities. Postoperatively, she demonstrates decreased athetosis along with improved hand posture and coordination. Her speech was also affected.
I talk not very nicely.
Postoperatively, her speech was markedly improved.
Cut my throat, I can use the spoon better.
Walking was characterized by a spastic type of gait. Postoperatively, during ambulation, her stability, speed, and smoothness of her gait improved. Eight years later, she is shown performing gymnastic exercises and running, all of which she was not capable of prior to spinal cord stimulation. With a 3-year history of multiple sclerosis, this patient's symptoms were ataxia and severe intention tremor. She had been essentially wheelchair-bound and had been so for 1 year prior to admission. Because of bladder incontinency, she required an indwelling catheter. One year postoperatively, having undergone the implantation of the spinal cord stimulator system, she demonstrates a marked improvement in motor function, a reduction in intention tremor, and a decrease in ataxia. Her bladder function has also returned. With a 12-year history of multiple sclerosis, this patient's symptoms were ataxic gait, bilateral weakness, and poor coordination in his hands and legs. He could not write well, which was of significance since he was a banker, nor could he drink from a cup. His walking improved, and his strength and coordination in the upper and lower extremities has increased. He can now write clearly, and drinking from a cup is no longer a problem. He had difficulty in keeping his right hand open. After spinal cord stimulation, the spasms that caused his hand to close were eliminated. With a 17-year history of multiple sclerosis, this patient experienced marked difficulty in walking, secondary to weakness in her hip flexors and severe spasticity in the lower extremities. She also suffered from urinary urgency and incontinency. Following stimulation, her walking improved. With relief of the spasticity and increased strength, her bladder function became normal. Suffering from primary cerebral degeneration, the patient's symptoms were severe intention tremor and progressive incoordination of both upper extremities, which had compromised the patient's activities of daily living, such as feeding herself. Head and neck tremor is also noted to be present during these motor activities. Postoperatively, there is a marked reduction in the patient's intention tremor. All activities of daily living were improved, such as feeding herself and drinking from a cup. Her general hand coordination and dexterity were increased, along with improved handwriting. Friedreich's ataxia for the last 10 years is manifested in this patient by the instability of her gait and ataxia. She was still able to ambulate utilizing a walker, but had great difficulty in controlling both feet. This is more manifest in the right foot than in the left. Postoperatively, the patient's stability and ataxia has been improved. The most marked change was in her ability to control both her feet when walking. Note the normal placement and greater control of her feet. This patient was referred by the Department of Neurology of the University of South Carolina. She had a 2-year history of Friedreich's ataxia with severe intention tremor, ataxia, and dysmetria of the upper extremities. The patient was totally dependent in activities of daily living because of the tremor. Her handwriting was illegible prior to spinal cord stimulation. Because of the severity of the tremors and incoordination, she was unable to feed or care for herself and relied completely on assistance. She also had a typical ataxic type gait, which required assistance at all times because of her instability and frequent falling episodes. Note that the patient demonstrates the typical pes cavus deformity in both feet. She was totally areflectic. 2 years post-operative, the patient demonstrates total relief of intention tremor, ataxia, and dysmetria. She is now able to maintain full and normal function in carrying out activities of daily living. Walking is markedly improved, with no ataxia being noted. Her coordination has sufficiently improved to allow such fine motor control functions as knitting. She is now married with children, and recently she and her husband won a dance contest. A 4-year history of progressive multiple sclerosis was marked by weakness and spasticity in both legs and bladder incontinency. With spinal cord stimulation, her bladder function returned to normal. Her walking improved due to an increase in strength and a reduction in spasticity in her legs. With a history of 6 years of post-traumatic epilepsy, this patient experienced intractable seizures characterized by 15 to 20 absence attacks a day, 3 to 4 grand mal seizures per week, and frequent drop attacks. His preoperative EEG is shown with a markedly abnormal pattern. An EEG taken 1 year following spinal cord stimulation demonstrates an ostensibly normal pattern. He has remained totally seizure-free for the last 4 years and he is no longer taking anticonvulsive medication. This patient had a 4-year history of progressive, painful, spasmodic torticollis. He had been unable to work for the last 2 years because of the torticollis and pain. One year after implantation of the spinal cord stimulation system, the patient has regained full movement to his head and neck with total relief from the severe pain. 5 years post-operative, the patient enjoys normal, pain-free function of his head and neck and has returned to full employment. Referred by the Michigan Neurosurgical Department, this patient had a 2-year history of spasmodic torticollis. Her head had become fixed and pulled to the left, but with no associated pain. She had been refractory to all medications. Ambulation intensified the jerking spasms of the head and neck. One year after implantation of the spinal cord stimulator system, the patient demonstrates complete relief of the spasmodic torticollis and the associated jerking movements during ambulation. The patient is a 42-year-old priest suffering from painful spasmodic torticollis of 4 years' duration. With the progression of the torticollis, his head became relatively fixed in its torticolic position. The patient demonstrates great difficulty in turning his head to the right. He was totally refractory to all medications. Nine years post-operatively, his range of motion has become normal and the constant pain eliminated. The torticollis had become so severe that he could not perform many duties required of him as a priest, such as saying Mass and giving communion. He has since returned to saying Mass, giving communion, and fulfilling all of his priestly duties. With a 3-year history of progressive, painful spastic torticollis, this patient's head had eventually become fixed in this posture with constant pain. At a stimulation of 1,000 Hertz with the spinal cord stimulation system, the patient's fixed head posture was reversed. Her constant pain was relieved, and spasms previously present during ambulation are abolished. Progressive, painful spasmodic torticollis of 2 years' duration required a neck brace to manage the retrocolic spasms in this patient. Post-operatively, he was able to discard the neck brace and was totally relieved of the constant pain. The retrocolic made it difficult for him to write or eat. Post-operatively, he could hold his head in a normal position whenever he wrote or ate. He was refractory to all forms of management, including biofeedback, traction, and medications, to which he had severe reactions. He would often trip and fall while walking because he could not see the ground. Post-operatively, he is able to look down while walking, and as a result, the danger of tripping and falling has been greatly reduced. With a history of severe, painful, spasmodic torticollis of 2 years, this patient's head was fixed in an anticolic position. He could only move his head with great difficulty and discomfort. The anticolic posture was relieved to the point that his head returned to the neutral position, and the pain that was located in the back of his neck was relieved. During ambulation, his head remained in the fixed anticolic position with persistent pain and discomfort. He now ambulates free of pain and discomfort, and he can hold his head in a normal position. This patient was referred by the Yale Neurology Department with a 5-year history of severe, painful, spasmodic torticollis, which pulled his head to the right. The patient demonstrates the variety of facial sensory inputs that he utilized to temporarily overcome the spasmodic torticollis. Also to be noted is the marked slowness of the patient's movements in carrying out various manual dexterity functions. The patient is shown 1 year postoperatively with complete relief of his spasmodic torticollis, pain, and an increase in the speed of various motor functions. With a 5-year history of torticollis, this patient experienced painful spasms from 10 to 15 times a day. At times, the pain was so severe that she would pass out. Note the loss of the left sternocleidomastoid muscle in her neck, which was the result of a resection of the 11th cranial nerve, which was done at another institution. 1 year postoperatively, the patient's pain has been completely relieved. Left and right movement has been increased, although anti- and retrocolic movement is still somewhat limited. Three years postoperatively, the patient's movement is further increased, most notably in anti- and retrocolic movement. One year following the onset of his spasmodic torticollis, this patient's head became fixed, turned to the left and with no motility, and a source of constant pain. The intensification of his torticollis during ambulation is demonstrated. 7 years after the implantation of the spinal cord stimulator system, he demonstrates complete relief of his torticollis and pain. His head and neck motility have returned to normal. This patient had a 4-year history of progressive, painful axial dystonia and no peripheral symptomatology. Due to her instability, for the last 3 years, the patient was able to ambulate only with a great deal of difficulty and support. The patient's axial dystonia has improved, and the painful spasms have been relieved 1 year after spinal cord stimulation. Referred by the New York Neurologic Institute, this patient had a 5-year history of progressive axial dystonia with extreme, painful, exaggerated kyphosis and loss of associated movements. The dystonia had also produced an almost intelligible spastic dysphonic speech. As a result, he had to give up his practice as an attorney. 2 years postoperatively, the patient demonstrates complete relief of the axial dystonia and pain. His speech has sufficiently improved for him to resume his practice as an attorney and open his own law office. With dystonia in both her father and brother, this patient had severe progressive dystonia for 28 years. She had dystonic posturing and deformities of all extremities and of the head and neck. Bilateral thalamectomies performed at another institution failed to relieve her symptoms. 8 years post-operative, her posture and motor function have improved, and she has become more self-sufficient in activities of daily living. Dystonia of 2 years' duration in this 10-year-old male manifested in the upper extremities. It was characterized by pronation, trembling, and marked difficulty in opening and closing his left hand. Due to the progression of the dystonia in his hands, the patient eventually changed from left to right-handedness. Following implantation of the spinal cord stimulation system, the dystonic, athertotic posturing and trembling of the left hand was abolished. He is now capable of opening and closing his hand with ease. He demonstrates bradykinetic movements of his hands during writing. His speech was also very slow.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Post-operatively, his speech became normalized.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
The improvement in his hands is further demonstrated by the speed that he uncaps the pen and writes. Preoperatively, the lack of dexterity in his hands is further demonstrated by difficulty in picking up a cup. His manual dexterity improved to the point that he can now pick up a cup without any difficulty. This patient had a 13-year history of progressive, painful dystonia involving the face, the whole body, both axial and peripheral, along with difficulty in swallowing and abdominal spasms. She required assistance in all activities of daily living. After 4 days of spinal cord stimulation, the patient's painful dystonia is totally relieved. The abdominal spasms were gone and swallowing normalized. She could now perform activities of daily living unaided. Uncontrolled nodding of the head, which at times was violent, is demonstrated by this patient with a 4-year history of woodpecker dystonia. Post-operatively, the constant involuntary nodding of the head was relieved. Referred by the UCLA Department of Neurosurgery, this patient suffered from severe oral facial dystonia for 3 years. In association with the facial dystonia, her speech was also severely affected.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
She is shown following implantation of the 4-electrode quadrupolar system with a relief of her oral facial dystonia. Her speech was also improved.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
This 14-year-old male had a 7-year history of dystonia in the right hand. A thalamectomy performed at another institution did not alleviate the symptom. Although he was capable of making a fist, he was unable to open his hand unassisted. Only by helping with his left hand could the fist be opened. After 30 days of spinal cord stimulation, he could freely open and close his right hand. He now has full function of his right hand for all activities of daily living. This 23-year-old woman had suffered from progressive dystonia, which began at the age of 10. The severe, painful axial and peripheral spasms were refractory to all medications and bilateral thalamic surgery. In the space of 13 years, she had become totally disabled. With spinal cord stimulation, her axial dystonia was reversed. Her painful spasms were abolished, which freed her from a wheelchair existence. Activities of daily living returned her to total independence. Severe dystonic movements of the head, neck, and trunk are exhibited in this patient with a 2½ year history of dystonia. Associated with the abnormal movements were facial grimacing and cervical pain. The patient also experienced a relatively retrocolic pulling of the head and neck. Following implantation of the spinal cord stimulation system, he demonstrates marked relief of the head and neck, absence of facial grimacing, and total relief of the severe cervical pain. A slight titubation may still be noted during ambulation. With a 20-year history of progressive, painful axial and peripheral dystonia, the patient experienced severe retrocollis and scoliosis. The marked dystonia of the thoracic muscles produced a fixed, comma-like posturing of the spine. There was continuous abnormal movement of the right arm. She was last able to walk unassisted 15 years ago. The patient was refractory to all medications and bilateral thalamectomies performed at another institution. Spinal cord stimulation has resulted in relief of the pain and improvement in the axial and peripheral dystonia. The patient has been on spinal cord stimulation for 3 years, and her activities of daily living have been improved, along with her quality of life. With a 31-year history of dystonia, this 46-year-old patient's symptoms began in the right hand and progressed to the point that even simple tasks, such as writing, became slow and laborious. Demonstrated here, the patient requires 15 seconds to write her initials. After 3 days of spinal cord stimulation, she requires only 2 seconds to accomplish the same task. Both her lower extremities were severely involved with painful spasms and the typical equinus varus posturing of the feet. Total relief from the painful spasms and the equinus varus posturing of the feet was experienced after spinal cord stimulation. Her dystonic posturing and spasms had progressed to the point that she was unable to ambulate even with assistance. At times, she required morphine sulfate for relief of the painful spasms. The patient is now able to ambulate normally, free of pain and dystonic spasms. "4 years later, in a videotape provided by the patient, She demonstrates the increased dexterity in her hands by crocheting and her continued ability to write. Her ability to now drive a car, a task that was impossible for her prior to spinal cord stimulation, is demonstrated. Daily walks are now common for her due to the total elimination of the painful dystonic spasms and posturing in her feet. With the complete relief of the spasmodic pain, she no longer requires any morphine sulfate. The 4-electrode programmable spinal cord stimulator system is implanted through a 16-gauge pericutaneous needle, which is inserted in the midline, approximately opposite the spinous process of D7. By palpation, the D7 lamina is identified, and the needle is slipped over the lip of the lamina into the epidural space. The position of the needle is confirmed with an injection of normal saline solution. If the saline is not easily accepted, the epidural space has not been reached. The needle is then advanced until the saline can be injected. Under fluoroscopic control, a test lead is inserted through the pericutaneous needle into the midline epidural space to delineate the path that the electrode assembly will follow. The test lead also indicates any possible obstruction around which the electrode assembly may have to be directed. In this lateral view of the neck, the test lead is passed upwards to the C2 spine. The test lead is then removed, and the 4-electrode assembly is inserted. The electrode assembly is steerable, and should any obstruction be encountered in its path, it can be steered around the obstruction so that the midline position can be maintained. Once the electrode assembly is properly positioned, the pericutaneous needle is removed and a subcutaneous pocket is prepared for the receiver. The terminal end of the electrode assembly is then passed subcutaneously to the receiver pocket, where it is connected to the programmable receiver, which contains within it an integrated circuit capable of converting coded radiofrequency signals into minute electrical impulses. The computerized receiver is then inserted into the previously prepared subcutaneous pocket. Following implantation, stimulation is carried out by an external computerized transmitter and its antenna. The antenna is placed over the implanted receiver and produces transcutaneous induction of the receiver. The control panel in the transmitter allows complete access to all possible electrode combinations in both mono and biphasic stimulation modes, and pulse widths from 50 to 500 microseconds. A frequency analysis is performed of the patient's response to selected frequencies ranging from 100 to 1500 hertz. The electrical impulses emanating from the electrode assembly pass through the dura to the underlying neural structures of the spinal cord, creating within an applied field. Depolarization and hyperpolarization are seen as the stimulation parameters are changed from mono to bipolar fields, which is illustrated with the positive fixed at the number 4 electrode. The negative is then moved from the number 1 electrode to the number 2 electrode, and then to the number 3 electrode. The stimulation pattern is further changed as 2 positives are coupled with 2 adjacent negatives, or by alternating the positions of the positives and negatives, and still further accentuating the area of depolarization with a single negative flanked by positives. The multi-level programmable spinal cord stimulator permits stimulation of a selected level of the spinal cord, and the pattern, the polarity, and the frequency of the applied field. all of which must be individualized in each patient.